There's quite a discussion in prostate cancer for some time now if patients with limited metastatic disease, so they get diagnosed and they have like the prostate cancer has spread to the bones in a limited fashion, normally 1 to 3 or even up to 5 spots, if these patients benefit from local treatment. Classically, you can do this with radiotherapy or with radical prostatectomy. Both surgery or radiotherapy are established treatments for prostate cancer. And that's where we come from. For many diseases, we know that treatment of the primary tumor improves cancer control outcomes. And we were wondering if this is also true for radical prostatectomy. That's why we initiated the RAMPP trial. So we randomized patients with oligometastatic prostate cancer. They were diagnosed with oligometastatic cancer in the beginning. They were staged by conventional or also molecular imaging. About 1/3 of patients had molecular imaging at the beginning. And we randomized them to best systemic treatment, which means like endocrine deprivation therapy, enzalutamide, etc., with or without radical prostatectomy as local treatment alternative. We randomized 132 patients. The study was preliminarily closed due to the fact that the STAMPEDE Arm A trial was published, which showed a significant improvement of survival in patients with radiotherapy to the local tumor. However, we believed in this moment that it's not ethical anymore to offer no local treatment because it showed, of course, efficacy in this cohort. So we randomized 132 patients. We followed them up all for 5 years, and we evaluated as a primary outcome the cancer-specific mortality. Our results, the primary endpoint, which was cancer-specific mortality, was reached. We have a significant improvement in cancer-specific mortality after 5 years for patients who received radical prostatectomy additionally to the systemic treatment. Of note, one has to say that in the best systemic treatment arm, more patients initially got more aggressive systemic treatment, like more chemotherapy, more next generation androgen receptor inhibitors. So despite that fact, even then we've seen like a nearly 10% reduction of cancer-specific mortality after 5 years, sorry. So I think what we can say now is that radiotherapy and radical prostatectomy both should be performed in patients with limited metastatic spread at the diagnosis. I think both treatment modalities have their pros and cons, but both have consistently shown improved cancer-specific survival advantages, so patients benefit from this. However, we have to be aware that the complications after this kind of surgery are higher than in normal radical prostatectomy patients, which makes also totally sense. They are more advanced stages, but this has to be counseled before we opt for surgery in patients.